I'm here today to talk about AI approaches in improving the accuracy, the utility, and the throughput of diagnostic imaging in prostate cancer, and specifically both with radiology and with pathology imaging. Thank you to Dr. Manis for your advice on helping focus the topic. Let's outline the objectives of the presentation. First, I want to introduce some basic principles of ML and AI and establish why there's interest in applying it to prostate cancer. And then I want to explore some of the bigger and more recent advances in the space and appraise these papers with a particular eye towards the actual future implementations of these algorithms in real clinical practice. I'll largely be avoiding the technical specifics of how the ML models are built, aside from what is necessary to know in order to appraise papers better in this space. Other than that, I have no disclosures to make, and I also want to acknowledge before beginning that I'm delivering this presentation on the traditional, ancestral, and unceded lands of the Coast Salish, Musqueam, Squamish, and Tsleil-Waututh nations. So it'll be useful to properly define AI and machine learning and distinguish that from statistical learning overall. AI broadly is something that attempts to mimic human behavior. So making decisions based on data is human behavior. So in some sense, like linear regression is a form of AI if you dress it up right. So there's that overlap with data science as a whole. Now, machine learning is a bit more of a focused term, although colloquially it's still abused a lot. Traditionally, when you feed data into a computer, you apply an algorithm with that data, and then the computer works with that and then spits out an output. But in ML, you give it data and you give it outputs, and then it trains, it makes an algorithm, and then you feed an algorithm, new data to that algorithm, and then it creates the output. And that algorithm can be arbitrarily complex. When I talk about ML and AI in this presentation, I'm going to be focusing specifically on models that fall even more narrowly within what might be properly referred to as deep learning. And that too can be pretty vaguely defined. But the implication is that those models are using more advanced ML techniques. They're using more specialized optimization algorithms, more training steps and layers. And they tend to handle broader scopes of data from images to time series and sometimes combining all of these things to come up with results. So what's the point? What's the point of ML and AI and deep learning? And I would say in a nutshell, it's doing statistics and making decisions on complex data. And to illustrate that point, here's a little toy problem where you have this Cartesian coordinate grid with yellow and blue points, and it's split between these quadrants in an unusual but pretty clear way where all the yellow points are here and here, and all the blue points are here and here. And when you try to feed it into a linear model, it fails to segment the points because it's missing all these blue points over here. But if you apply even a very rudimentary neural network with just one hidden layer, it segments the dots perfectly. And that's the advantage of ML models in a nutshell. It's modeling complexity. But on top of that, when it comes to non-tabular data or other unusual data types like images, the types of analysis you need to do are going to be more sophisticated. So what you're looking at here are advertising materials from this company called Avenda Health, which received some fashion of FDA approval for their product called Unfold AI. And it's for AI-based prostate cancer decision support. And in the pictures, they advertise this model that reads prostate MRIs, and it identifies areas of concern that ultimately corresponded to surgical pathology. Now, you can't exactly draw a line through a bunch of prostate MRIs with cancer. Well, actually, you can with some creative feature engineering, but it won't be very good. You generally have to use some deep learning method to analyze data like this. What's also interesting is that you'll see that the model isn't just telling you that there is or isn't cancer in the MRI, it's telling you where it is. And there's a huge variety of these so-called explanatory ML models that not only allow you to make predictions, but allow you to interrogate the model specifically for what they are assigning importance to in the data. And this is called a class activation map technique. And then you can inspect the class activation map and see where the model is looking at in order to make a prediction. So you can have an ML model look at an image and then tell you which parts had the highest impact in swaying the final output. So now we're at this point where we ask, why do we need AI in prostate cancer? What's wrong with radiologists or pathologists? And in order to start seeing what the value of AI in the space might be, here's some sobering statistics. In 2024, there was a Lancet Commission on prostate cancer, and they published a review where they highlighted the surge in prostate cancer now and in coming years. And in particular, they point out three big things. One, the number of new cases is going to rise from 1.4 million a year in 2020 to 2.9 million a year in 2040. Two, the projected rise in prostate cancer is happening everywhere around the world. And two, it can't be prevented by lifestyle changes or public health interventions. And three, there's an increasing late diagnosis of prostate cancer, especially in low to middle income countries, but it's spread worldwide, really. Now, like I said, late diagnosis is a problem everywhere, but especially in LMICs, which have less access to proper radiology, proper pathology, proper urology services. And so in response to that specific issue, the commission points out explicitly that early diagnosis systems need to integrate the growing power of artificial intelligence to aid the interpretations of scans and biopsy specimens. And on top of that, on top of the increased burden of prostate cancer that we're projecting, the workforce of people available to make all of these reads for histology and histology and radiology is decreasing. So in North America, the total number of pathologists has decreased each year, it seems, from 2007 to 2017 by about 17%. And in the same time frame, the diagnostic workload has increased by like 40%. So this graph on the left is a projection moving forward after that from 2018 to 2030. And what we see is the relative workforce is projected to be going down even further. And then you look at the map on the right, and it shows, of course, that LMICs in particular, in Asia, Africa, have pathologists in rare supply. And radiology, too, is kind of a similar situation, although that graph is not for radiologists. So it's not hard to come to the same conclusion as the Lancet Commission looking at this data, that perhaps artificial intelligence is part of the solution. Now, when it comes to the prostate cancer diagnostic and treatment pathway, if anything involves a decision, somebody has probably tried to apply AI to it, from who to screen to who to send to MRI, for obtaining and interpreting that scan to send someone from a biopsy, to even doing the fusion of the MRI and the ultrasound for the biopsy, to interpreting the biopsy results, to risk stratification, even elements of the initial treatment and beyond. So people have applied AI to everything. And in prostate cancer, a lot of these decisions aren't easy, and a lot of them are labor intensive, and they incorporate several data types. As we know, sending someone for futile testing or futile treatment is detrimental, and it's a clinical priority in prostate cancer to avoid overtesting or overtreatment of indolent disease, but also accurately identify and treat clinically significant prostate cancer. So narrowing down then, let's begin with how AI is being applied to prostate MRI. Although multi-parametric and more increasingly biparametric MRI are definitely useful, there are still multiple open issues for MRI and prostate cancer. MRI has a 10 to 20% false negative rate for clinically significant prostate cancer, and the false positive rate, i.e. Overcalling clinically insignificant prostate cancer, in studies can approach as high as 50%, especially with the more intermediate PIRADS calls. Prostate MRIs are hard to read, and in the figure on the right, we have three major maps for sample prostate biparametric MRIs, T2-weighted DWI ADC maps, and then this is two separate patients. And the authors in this study for this figure, they just show that the relative intensity values for each of those sequences between what is demarcated as benign tissue and what is demarcated as cancerous, the intensity oftentimes overlaps quite a lot. And of course, reading and recognizing cancer is not just differentiating intensities, but also comparing the shape and the intensity change across sequences. But you can see that there's a fair amount of overlap between those intensities, and it's easy to appreciate looking at a lot of these that this is a hard thing to do, and it takes a long time to read. And there's a substantial amount of inter-observer variability as a result. And that inter-observer variability is well studied, and it varies based on the location of the lesion and especially based on the experience of the observer. The figure in the top left demonstrates a lack of agreement in PIRADS readings, really regardless of reader experience, especially with the PIRADS 3 calls. And that changes and generally gets worse as the agreement gets worse as your reader experience goes down. And that's fairly well known. And in the bottom left, we see a figure from a paper not only showing interreader variability, but also a substantial amount of inter-site variability in the positive predictive value of MP-MRIs. And some of these sites have rather poor positive predictive value. And there's all manner of technical parameters, radiology team factors, patient factors that can all impair the quality of a scan. So the positive predictive value of reads can vary quite widely from site to site, and the variance is stark. So naturally, there's good interest in using AI to improve image quality and acquisition. And there's a number of papers in this field, but I felt this article from Bischoff et al., published in Radiology in 2023, was a good example of work in the space. So here they use this deep learning based algorithm. It's some industry algorithm. And they were able to improve the qualitative appearance and diagnostic utility of an MRI, and then also quantitatively improve the acquisition time. And the way they did this was they took low resolution T2 weighted turbo spin echo prostate MRIs, and then they used a deep learning algorithm on those scans. So that's called T2DL. It's the scans on the right side. So all of these figures are shown in groups of 3, and it's the scans on the right side. Okay. And then they compared that to 2 conventional sequence types called T2C and NC, Cartesian and non-Cartesian, which are more standard and reasonably high quality, but they take longer to do. And here they demonstrated in their paper 3 things. 1, there was good PIRADS reading agreement between the faster AI-powered sequence and the other sequences with a kappa of 0.92 to 0.94. So it was really, really good. The agreement with what is typically considered the gold standard, which is just the real MRI. And then their algorithm, importantly, was also able to reduce motion artifact. And an example of that is shown in figure 1, in the figure 1 images in the left, where it's a bit hard to appreciate because I've kind of shrunk it down, but the deep learning images, frankly, just look to be higher resolution. And then qualitatively, they also just did questionnaires on the radiologists participating in the study. And you can see that in terms of the number of artifacts or the image sharpness or the lesion conspicuity, overall for all the deep learning based MRI images, that radiologists felt like those images were better with respect to all of these different parameters. And you can tell because there's more green in these bars than for the 2 conventional sequences. And then they also measured the signal to noise ratio, and then they measured the acquisition time. And you notice that the acquisition time for the deep learning based acquisition setup is basically half as much as the other 2 conventional sequences. Now, the study, while prospective, had no component where the AI-based images were compared in terms of actual patient-relevant outcomes. So it's not in a stage where it could be implemented into clinical practice yet, but there's some good face validity here for the next step. And then also all MRI sequences, no matter the vendor and really no matter the machine, they all undergo post-processing before they end up on a radiologist's workstation. So in a sense, you're just philosophically thinking about it, an AI-based a reconstruction is kind of possibly just an upgrade of existing processes. And it's not necessarily the voodoo that some people might have the intuition that it is. But when it comes to acquisition, this is good. This is great, actually. But I think this is not specifically what people think about when they think about AI and prostate cancer. I think they think more about image interpretation rather than quality improvement for a radiologist. Or they're thinking of automatic organ segmentation or lesion detection and grading. So let's talk about that in a bit. We'll get to that. But first, it's worth discussing some of the challenges in leveraging this rich prostate MRI data for making AI models to detect lesions. there are big differences between MRI scanners, MRI models, how they encode data. And yes, images are generally all saved as DICOMs, which is the de facto standard for medical imaging data. But the DICOMs have headers that differ in crucial geometric information like orientation or voxel size details. And then on top of that, many MRIs are taken with different protocols, like multi-parametric protocols with 3 Tesla machines, or in other cases, biparametric protocols with 1.5 Tesla machines, or with or without an endorectal coil, et cetera, et cetera. And especially with increasing evidence that dynamic contrast enhancement has a limited role in the detection of prostate cancer, things are kind of changing all the time with the protocols in use. And it changes from patient to patient too, where it's really the intermediate and high risk rather than the low risk or very high risk patients that are getting the contrast. So my point is, pragmatically speaking, AI models need to be able to take into account these differences in how the MRI is done if they're meant to be clinically applicable. And in many AI studies, the sensitivities to domain shifts are often unconsidered, and many models are based on data sets using one group of MRI machines. Now that we understand this, we can start going into the evidence on AI-powered MRI interpretation. And there's a lot of material to look at, not all of which is exceedingly high quality. But this is the opposite. This, I think, is the single best paper in the space so far. It's this Lancet Oncology paper from Saha et al. Just from 3 months ago. And I think it's an excellent study. It's titled Artificial Intelligence in Radiologists and Prostate Cancer Detection on MRI, PIKI. And it's an international paired non-inferiority confirmatory study. I think the study it doesn't say it's a retrospective cohort study, but it serves as a great example of how you can make the most of retrospective cohort data. Let's go through a broad strokes visual abstract. This was a multi-center retrospective cohort analysis where they started off with 10,000 MRI scans from about 9,000 patients from multiple centers, all in Northern Europe. And 2,400 of those scans had pathology confirmed Gleason grade 2 or higher prostate cancer. And there were exclusion criteria. So there were about 4,500 scans that were excluded for various reasons, but they were for reasonable pre-specified factors such as prior prostate treatment, incomplete data, and so forth. And to their credit, they made study flow diagrams for every single center in their supplementary. So then what they did with those 10,000 scans is they took 9,000 of them and they used that in the training of an ensemble AI model. And I'll get into more detail later about the AI models and how they were made. But ensemble just means that it's an average of a collection of AI models. Okay. So getting those models, they then train those models on those 9,000 scans. And then 1,000 of the scans is kept for a holdout testing data set. So when the model is training, it doesn't get any access to that data set, that holdout test data set. These test scans were then read by 3 different groups. The first is, of course, the ensemble AI model. The second is 62 international experienced radiologists, but they only read 400 of the 1,000 scans selected at random. And then the third group is the historical multidisciplinary routine practice diagnoses. And how that differs from the radiologists read from the second group here is that the radiologists that initially read the MRI scans, they had access to all the patient data, PSA values, patient history, like other people's notes, that kind of thing. And then one thing I'd note here as well is that there was a reference standard here where a good chunk of those 1,000 scans had biopsy results and 3-year follow-up, even for a lot of the negative MRIs, which I'll explain in a bit how that happened. But this reference standard wasn't directly compared to, but it was used for a calculation of certain statistics in the results. When comparing the AI model to the pool of the 62 radiologists, the primary outcome test statistic was area under the receiver operating characteristic curve, which is basically a composite of sensitivity and specificity. And then when comparing the AI system to the radiology reads historically with multidisciplinary practice, they define the test statistic as the difference in specificity at the same sensitivity at a PI-RADS 3 or greater call. So this was all heavily pre-specified analysis, which is excellent and not necessarily true of many papers in the space. So talking a little bit about the construction of the AI models, what this group did was they hosted a challenge online on grandchallenge.org. That's a fairly common like website for like different domains, even in engineering or other domains of medicine, where groups are looking to make AI models. They'll just host their data, and then people will publicly like throw their hat in the ring, and they'll try to make a model for that data so they can get their name out there. And it's a nice way to like crowdsource a lot of the effort and the time and energy it takes to build a model. But of course, collating data and then like assembling it in a way that other people can access is also a ton of work on its own. So it's not like, anyway, the point is that they were able to get some really smart people from around the world to give their best shot at building really good models. And they have a leaderboard. And what happens is over 300 people submitted a model, like they built their own model and they submitted their model. And this group, PyKI, is able to pick the 5 best models. And those 5 top models were then allowed to finish training on a bigger portion of the 9,000 scans. So only about like 1,500 scans were given out for free. But the rest of the 9,000 were then trained using those 5 best models. And then the final AI model is just an ensemble direct average of the 5 models. On the right side, we're just looking at the architectures diagrams for a couple of the models that were eventually selected. And I won't talk too much, I won't go too deeply into it, but I'll just point out that these architectures are actually pretty common. They use things like UNet and ResNet. These are like very common for image interpretation, both inside and outside medicine. So nothing exceedingly fancy here, but very performant stuff. So keep in mind that this is a study that's powered entirely with retrospective data, which means that it's very susceptible to sampling bias. So I think it's important to have a very close look at the table of ones for this study and the study flow diagrams, and just to see how bad that sampling bias might be. But please don't squint. I'm just showing the table to illustrate only a couple points. One, the patient population is quite representative of what you would see in typical practice. And none of the sub-data sets for the testing or training, training or development splits or the hidden testing cohort is like really out of the ordinary in terms of baseline patient characteristics. And then we can also see that the overall rate of pathology confirmed cancer in the larger cohort in the testing split is 25% Gleason grade 2 or worse. So that's 75% benign pathology or GG1, which is about what you would expect in practice. While a comparison to histopathology results is not really a primary outcome of the study, it is a very important one. And if you recall, like the comparisons are technically made from AI read to radiologist read and AI read to multidisciplinary read. But the histopathology read isn't directly compared to, but it's the reference standard. So not everybody has histopathology because this is retrospective data on MRI scans, and not everybody would get a biopsy after. But you can't just exclude everybody who doesn't meet that gold standard, because if you did exclude people without histopathology, then you'd be artificially losing a lot of training scans with negative MRIs. Because if you're MRI negative, you are exactly the type of person who doesn't get a biopsy or surgery. But MRI negative scans are about half the typical population getting MRI scans. So like you're kind of in this catch-22 where you're retrospectively collecting data and you want to be inclusive of as many scans as possible, but you want a reference standard for all those MRIs. But if you have a bunch of negative MRIs, you don't have a good reference standard for those people. So one thing that the study did that I thought was really interesting was they were able to take advantage of the fact that many of these patients' scans who were put into the study were also enrolled in the 4M trial over here, which was just comparing trust to, they were involved in like a couple of trials where basically the people got systematic biopsies regardless of their MRI results. And so what ended up happening is that from each cohort, from their location. Intermittently, they would have like a group of like 100 or 200 or whatever people that got a biopsy even though they had a negative MRI result. And those people were preferentially put into the testing cohort of 1,000 people. And so even though 517 out of 1,000 people had negative MRIs, 63% of those negative MRIs still had histopathology results, which I think is really, really interesting. So that's quite remarkable. There. Again, don't squint, but earlier I was trying to impress that there was a lot of variability in scanner protocols and the acquisition of MRI images. And this paper has gone through to great lengths to showcase in their supplementaries some external validity by showing the diversity of their hardware and their protocols. It's still mostly like 90% of the MRIs were from Siemens Healthineers. But overall, there's a reasonably broad variety of parameters for acquisition of different phases and voxel size and things like that. No, it doesn't seem like endorectal coils were used very much at all, though. Okay, so now for the results. Overall, the results were that the ensemble results from top performing AI systems, when compared to the 62 radiologists, which were not given the whole multidisciplinary story, and were recruited specifically for the study. Overall, the AI system outperformed in blue the radiologists in red. And we can see that at a PIRADS 3, 6.8% more clinically significant prostate cancer was detected at a single specificity of like about 0.6. And we can see that that's true even at PIRADS 4 and PIRADS 5, where overall the sensitivity is just much improved and the specificity is much improved. So comparing the area under the ROC curves, that's 0.91 to 0.86. So it's good both ways, but the AI system did outperform. Yeah. When it's comparing to the multidisciplinary practice reads, though, what we see is that the AI system did not precisely beat the superiority margin like it did with the comparison to the 62 radiologists, but it still does beat the non-inferiority margin. And so part of the issue there is that the thing is, like, even though a lot of those negative MRIs still had histopathology, like a good chunk of them didn't, right? And so any study like this is going to be systematically biased against the AI system. Because for all of those negative MRIs where, let's say, the AI system thinks, hey, I think there's a lesion there, or I think that there's cancer there, there's no way to verify that ground truth, right? Because you have to just assume that the original read was correct because there's no reference standard to go off of. And so I think overall, like demonstrating non-inferiority is not an unreasonable thing to do. But moreover, you kind of have to like, my point is that you can demonstrate non-inferiority, but I don't think that paper was intended to ever try to demonstrate superiority. And that's exactly what they say in their pre-specified analysis. So it's quite impressive that it still like did what it set out to do, which was demonstrate non-inferiority despite being hamstrung in that way. The supplementary figure here shows a distribution of false positives and false negatives predicted by the AI system and radiologists in the hidden testing cohort. And it's all stratified by Gleason grade group or by PIRADS read. And I want to draw your eye to the overall trends, which I've tried to highlight with the gray bars. So the first bar you're looking at in each of these pairs is the AI system, and the second bar is the radiologist. So the first bar is the AI system, and the first bar is the AI system, and the second bar is the radiology reads in multidisciplinary practice. And overall, what you can see is that the trends are that every single time the AI system has fewer false positives and fewer false negatives, regardless of whether it's making the PIRADS call of 3 or more, or 4 or more, or 5 or more. Same situation here with the false negatives. It's the comparator group that's having more false negatives. When it comes to comparison with the radiology reads made originally That trend is a little bit less there, but you can see it in some of these groups with PIRADS 4 and 5 lesions for false positives, and then PIRADS 5 lesions only for false negatives. So overall, the system resulted in 50% fewer false positive results and detected 20% fewer Gleason grade group 1 cancers while maintaining the same sensitivity as the independent radiologist. So I think it's a very, very impressive results overall. Now, the ground truth in the study, the reference standard was histopathology results, and that's a good thing. But the primary outcome was not that. It was still technically comparing to other human reads. It's not precisely a patient relevant outcome. And also, this is ultimately retrospective data too. It's well done, but it's limited. And at best, the quality of evidence is 2B, which the patient points out itself. Now, I'm sure many people will have different opinions on what the ideal trial would look like for a study like this, but I think most people would agree that prospective data would be needed at this stage. And moreover, I would say that prospective data will ideally include some type of comparison to actual patient outcomes. This is a choice. This is an issue with many of the choices for ground truth used in many of these AI studies, whether for radiology or pathology, where comparisons and agreement, it's calculated for original radiology reads or for histopathology, a Gleason score. But the predictive value of many of these kind of arbitrary classification schemes is that they don't necessarily correspond very well to what patients actually care about, which is biochemical recurrence, overall survival, conversion to metastasis, that kind of thing. At the end of that Lancet Oncology paper, they referenced this trial, which isn't published yet, called the CHANGE study. It's a planned prospective multi-center assessment of AI non-inferiority as compared to the PIRADS score for reading multiparametric MRIs. So like I said, it's multi-center, it's multi-vendor, and so the results are meant to be generalizable. And what they plan on doing is they plan on taking 420 patients and with regular patient diagnostic pathways, they will obtain multiparametric MRIs. And of those people getting multiparametric MRIs, if indicated, those people will get a systematic biopsy. And that same cohort getting MRIs will also get a AI-based diagnosis. But that AI-based diagnosis is not used in any way to inform treatment decisions, like to get a biopsy. So again, you're in a situation where there's this bias introduced against the AI systems because the human radiologist assessment, by definition, can't be proved incorrect when you don't get the biopsy. And again, you're in the situation where non-inferiority can possibly be demonstrated, just given the direction of the systematic bias. But when it comes to the AI, I think being non-inferior is not the biggest impediment to uptake, although in resource scarce areas it might be. I think you have to demonstrate something like improved speed of reading or superiority in diagnostic capability to really have uptake. Or maybe a superiority diagnostic capability when combined with a human radiologist, like a computer-aided diagnosis. So this CHANGE study will maybe be able to evaluate non-inferiority prospectively, which is helpful, but it's not that final phase 3 clinch by any means. And so many of the studies in the space are really limited by their inability to have AI prospectively render any decisions. And the study will be expected to be done in around 2026. So the EAU put the statement out on AI and prostate cancer imaging, and of particular interest to the writers of that statement, they're really, really interested in concurrent reading scenarios where radiologists are assisted by AI-generated detections or the diagnosis of prostate cancer, and the diagnosis of prostate cancer. And various papers have shown some promising outcomes where the AI serves as a first reader to triage non-disease examinations, and then an actual radiologist comes in. And ideally, that boosts accuracy while reducing workload. Or other papers have shown an overlay, like a web overlay, where the radiologist has like a computer-aided diagnosis helper that is able to help them read it like in real time. Right. So this paper is a paper published in Investigative Radiology in 2021, where the title gives the conclusion. It's a novel, deep-based A deep learning-based computer-aided diagnosis system improves the accuracy and efficiency of radiologists in reading BPMRI images of the prostate. Basically, they had 7 relatively more junior readers read a bunch of studies, and they compared them to senior radiologists who were the ground truth, so to speak. And this is a crossover study design where the readers read in 2 different sessions, 1, 2, and then they crossed over. And on the right is a picture of that web platform that overlays lesion identification maps for prostate cancer, and they can toggle it on and off. And there's a bunch of different options there to kind of mimic their typical radiology workflow, but with nice little overlays. In broad strokes, the average accuracy of the radiologist in terms of area under the curve for the ROC curve in detecting clinically significant cases of prostate cancer, which was defined here as PI-RADS 4 or greater, was 0.85, which as in terms of an AUC is not bad. Just recognizing that 0.5 is the lowest you can be. Whereas when they were using deep learning computer-aided diagnosis, that went up from 0.85 to 0.88. So that's an improvement of 4.4%. And the p-value associated with that was 0.01. And then the inter-reader concordance, they also measured that, increased from a kappa of 0.22 to 0.36. And the p-value for that is 0.03. So the kappa is still not great, but it's much better. And also these are for relatively much more junior radiologists. Now, what we're looking at on the right here are density maps of the median reading time for each of the readers involved in the study, comparing the aided group, the computer-aided group in red, to the unaided group in blue. And what we see is that the average time to read the MRI was reduced by 21% from 103 seconds to 81 seconds. And the p-value for that is less than 0.001. Now, even without hard data on patient outcomes and very, very few participants in this study, this paper and many others are similarly looking into joint reading in AI and radiologists with computer-aided diagnosis systems. And I think it just adds on to the evidence of what we've got in the space, which is that, I think there's a lot of appetite for a CAD system, computer-aided diagnosis system, and a lot of face validity, at least, for potentially implementing it in future practice. Now, there is some meta-analysis type literature on this topic about identifying clinically significant prostate cancer in MRI, but the last meta-analysis is a little bit older. And to be honest, a lot of the studies that were included in it were of somewhat lower quality and really fell prey to a lot of the stuff that the Lancet Oncology paper didn't, with much lower sample size and less pre-specification and less variability in MRI protocols and things like that. So I won't go through this too much, but a lot of the area under the ROC curves for past studies in this topic were not nearly as good as what's been seen with this the more recent Saha et al. Paper. And so we really have moved forward quite a lot. Okay, so now let's move on to AI applications in histopathology. This will be interesting. So just like how there's issues with, consolidating so much variety in MRI data, pathology is no different. When you're taking stains of different tissues from lab to lab, from day to day, how you stain the images varies, and things like colors vary. So let's say one week comes by and your regular stain manufacturer is out of stock. You get a new H&E stain. The concentrations are all different. The source is different. There's a new histo tag. Everything's different and everything looks different. So how do you actually have an ML model train on that data when all the slides are literally colored differently? And what happens to a radiologist when, the colors change? And yeah, a pathologist should be able to distinguish between the two systems. But there is a role, one, for AI systems to help normalize stains, so stain normalization, by taking a template data and then applying the features of the template onto the source in order to make the normalized image. And so that's kind of an opportunity for AI to be involved in digital pathology. I wrote down MRI interpretation here. That's not right. Uh, to be involved in digital pathology. And then also that process is important for the um, digital pathologist and the AI models to be able to interpret that data better. Now, unfortunately, the challenges compound even further where, quite frankly, there's so much diversity in, like all the different types of pathologies you can look at, the slides you can look at, even when you're just looking at one type of specimen and the shape. So it's honestly a very, very large search space. And then when it comes to digital pathology in particular, the for whole slide images or WSIs, there's extremely large image dimensions. And so what you have to do in order for a graphics card to even be able to run a deep learning model on this data is you have to take small patches. And you can almost never actually like run the whole image. That's completely impossible. And so there's a ton of research actually in that topic alone about how you can have small patches kind of represent the whole slide image. And it's actually a really, really tough topic, to be honest. And then what's more is that unlike with radiology, it seems like overall in digital pathology, um, the systems for generating data and making publicly available data sets is just not as well developed. So you're going to see more publicly available data sets for MRIs or cross-sectional imaging than you will for histopathology in this space. I'd say some of the better evidence on this topic or the highest level evidence on this topic is going to be this systematic review from Morozov et al. That was published in one of the Lancet group journals, where it's just a systematic review and meta-analysis of a lot of the AI prostate cancer histology identification and grading systems. And so the population for this meta-analysis was patients with histologically verified prostate cancer. The intervention is AI assessment of histology. And the comparison or the ground truth is the histology assessment by pathologists, which again is not specifically patient-centered. And then the primary outcome for this paper, which I think again is a bit of a miss, is diagnostic accuracy for detecting any cancer at all. So just distinguishing benign from malignant, even if it's low-grade malignant, and then evaluating the agreement with pathologists for that. And then the secondary outcome is actually attempting to do Gleason grading. And in this whole quantitative synthesis, they've put together 24 papers through their search strategy. Well, we won't go through all 24 of those papers. It's too many. But what we're looking at the left here is, again, another area under the receiver operating characteristic curve where they were able to demonstrate really, really, really good AUC solely for distinguishing cancer from non-cancer. But as we discussed, it's really, really challenging to have this be clinically useful because the point is not necessarily to distinguish cancer from non-cancer, but you really, really need a good read because GG1 cancer is going to be treated very, very differently than higher grade cancer. And so actually, when it comes to grading, they don't have any figures like this because they weren't able to do a proper meta-analysis, unfortunately, because the state of the literature in this field is maybe a little bit less developed than it is for MRIs and MRI interpretation. But overall, the sensitivity for Gleason grading ranged from 77 to 87% and the specificity from 82 to 90%. But the accuracy is just overall lower. And then when it came to the identification of special types of patterns, they were able to comment that an AUC for cribriform pattern identification was roughly 0.8. But unfortunately, there's too much heterogeneity in the data to really make better curves or comment on other types of patterns that were identified to do a separate type of meta-analysis for those outcomes. So the bulk of this focused, unfortunately, on what I think is not as helpful, not a super helpful outcome, which is just distinguishing cancer from non-cancer. Again, Just like with MRIs, though, it's not all about diagnostic accuracy. It's about how a model can actually be used to help pathologists in day-to-day practice. And this is a study that was published in an open source journal, again, under the Lancet group. And the authors of this study made a AI model called ProCal LMD, where basically, as the title suggests, it's this artificial intelligence model for detecting pathological lymph node metastasis in prostate cancer using whole slide images. It's a retrospective study. Basically, these people already got radical prostatectomy with a lymph node dissection. And overall, they had 8,000 slides from 19,000 lymph nodes from 1,300 patients, all of whom had prostate cancer, of course. And they used that to train and validate this AI model. And the ground truth was experienced pathologist reads of that original data. And the long and short of this paper, without delving into the weeds too much, is that their model, ProCal LMD, demonstrated an AUROC of 0.979 in this cross-cancer data set. But I think what was more interesting than that, not just having a good accuracy when compared to expert pathologists, was more interesting than that is that this model triggered a true reclassification in about 43 of the slides, or 4.3% of the slides. So there was micrometastatic tumor burden that was initially missed by a pathologist, and then it corrected that, and then it was reread by the expert pathologist, and then they realized, oh, actually, yeah, we missed this. And so they had a little bit of follow-up because this is retrospective data, so they can go back and see those patients. And they found that within 5 years after their surgery, about 36% of those neglected patients experienced recurrence. And the baseline recurrence for all of their node negative patients, PM0 patients, was 19%. So there's the value there beyond just the face value accuracy in actually correcting missed reads. And then what's more that I liked about this paper was that a secondary validation study was done with junior pathologists rather than senior pathologists. And what they show is that the artificial intelligence algorithm boosted the diagnostic sensitivity of 2 junior pathologists. P-value was like just 0.04 to this level of senior pathologists. And then what it did was for all 4 pathologists, when they were given the artificial intelligence algorithm, it substantially reduced the reading time. So that's what we're looking at here. Reduced the reading time for all 4 pathologists. And that was more marked for the junior pathologists than it was for the senior pathologists, but the trend is pretty visible. So again, we're in this situation where, like, just beyond the accuracy, we're kind of asking different clinically relevant questions when it comes to actually adopting this in clinical practice. This I thought was an interesting paper, although it wasn't specifically just about prostate cancer. This is a Nature Medicine paper that was published a while back in 2019. Clinical grade computational pathology using weakly supervised deep learning on whole slide images. So broad strokes, made an AI model. It wasn't just for prostate cancer, although a lot of their data was for prostate. They also had breast and skin cancer. And then when they say weakly supervised here, weak doesn't mean bad thing. Weak means that they barely labeled anything at all. So in all of the other studies, the training data is basically an image, and then there's a specific label of an area in that image that corresponds to the cancer or corresponds to like where all the cells are not looking too great. And in this paper, what they've done is they've recognized it takes forever to segment that data. It takes forever to build those data sets, and it does. So what they did was they gave it the slide, the histology slide, and they just said there's cancer here or there's no cancer here. And that's way easier to collate than somebody having to manually segment and create each of those data sets. And what they found is that they had a really, really accurate prostate cancer model with the area under the curve 0.986. Again, just for distinguishing cancer from non-cancer, but I think it was very remarkable that they did this without having to actually label the images. So I won't talk too much more about this paper, but basically I'm saying that there's interesting stuff on the horizon with respect to really making the most of data without having to, you know, trudge through the weeds too much in the future. Now, when it comes to actually implementing in clinical practice, it's not just about what pathologists and radiologists think. It's also about what the patient thinks. And here's a paper published literally just last month about patient perspectives in the use of artificial intelligence and prostate cancer diagnosis on MRI. So it's not pathology, but MRI. And I'm starting to run out of time, I realize. But just to get to the point of it, it actually turns out that a lot of folks are very happy about getting MRI models. So there's a multi-center questionnaire study with 212 patients. And there was a pronounced preference actually for AI to aid a radiologist's judgment, with 79% of patients supporting a computer-generated second opinion after a radiologist's initial diagnosis, and 91% endorsing an AI's primary opinion subject to a radiologist's oversight. Only 15% of people are favoring a standalone, highly certain AI diagnosis without a radiologist output. But what happens is that from 15, they go to 50% if they're told that the AI model surpasses a radiologist in diagnostic accuracy. Now, interestingly, these people are all men because it's about prostate cancer, but is distinguished from similar studies in breast cancer, where women are much less likely to be interested in AI models and will still want a human in the loop, so to speak. So I think there's just a bit of like a interesting gender dichotomy there. Also,
5 minute warning, Rohit.
Okay, thanks, Dr. Lee. Chatting a little bit about where and how it's already in use. I will say that generally speaking, computer-aided diagnostic systems are not publicly taken up by any major hospitals, to my knowledge. And there's little practical advice on how to really integrate test results and recommendations. But a lot of these AI models, just for helping people read MRIs, has already received some flavor of FDA approval, but none of these systems are, quote, fully autonomous. And in all likelihood, none of them will ever be fully autonomous in the immediate future, just given the lack of higher level evidence. So we should expect to wait for anything like that on the horizon. A lot of these CAD models basically do segmentation, lesion annotation, that kind of thing. But again, not too much practical advice on how to integrate it. So in conclusion, then just getting into some takeaways. Not every AI model is equal. Making AI models is easy, but making and delivering good ones is very difficult. And the data that's often available is poor quality and not sufficiently generalizable. Data access is always a barrier. And implementing data access and deploying AI in a socially responsible and acceptable way is going to be challenging. I would say that the likely keys to strong AI models will lie in something called federated learning, where AI models can be developed from diverse data sources, like let's say from different hospitals or different groups that are pooled together. But the data are very highly secured because there's this process where each site builds its own model, and then it sends that to the federated server rather than sending the raw private data. So the analytic power is transferred, but the actual data remains secure. And then reinforcement learning will also be important, which basically just means that the model continues to adapt even after deployment. The other thing I want to point out is that, perhaps there's a lot of fields in medicine where AI is kind of a solution looking for a problem, but I don't think prostate cancer is one of them. I think it's clear that AI has a role to play here, especially in the acquisition and interpretation of radiology images, but also possibly in histopathology images, or either as a fully autonomous system, but more likely as a computer-aided diagnosis system in helping a radiologist or pathologist out. Like a pilot has a heads-up display. It doesn't need to be thought of as a crutch, right? It's an augmentation, and it can also be turned off if someone's in the learning process. So yeah, I know not too much time, but if there's any questions, I'm happy to take them.